Welcome to the ValueBased Care Perspectives podcast. In this show, award-winning healthcare executive Rani Khetarpal will take you on a journey of exploration focusing on the value-based care landscape and healthcare transformation. Here's your host, Rani Khetarpal.
Welcome, everybody, to our very first actual episode of Value-Based Care Perspectives. I am thrilled to introduce our first guest, Dr. Kashyap Patel. Those of you in the oncology world should know his name well, and like I mentioned, I'm just very excited to have him on the show today. So for those of you that are not aware of Dr. Patel's accomplishments, I just want to give you a brief background on him. Dr. Patel is the CEO of Carolina Blood and Cancer Associates in Rock Hill, South Carolina, and president of the Community Oncology Alliance, better known as COA. As a full-time practicing medical oncologist and board-certified in hematology, oncology, and internal medicine, Dr. Patel also volunteers with many other leading national cancer and quality organizations. He's a consultant and medical director for the Blue Cross Blue Shield of South Carolina, a CAC member for the Department of Health and Human Services, South Carolina, and Palmetto GBA. He's also medical director of the International Oncology Network, and Dr. Patel is also past president of the South Carolina Oncology Society and has served as chairman of several committees in numerous South Carolina hospitals. He has testified before the South Carolina State Senate and briefed countless members of the United States Congress and their staff on critical community oncology issues. He also is an extensive expert in value-based care, which is why he's on our show today. Dr. Patel has successfully led multiple oncology payment pilots in his practice and consulted on others across the state and across the nation. He has published and presented more than 70 original articles and abstracts in journals and or meetings, both nationally and internationally. And through his work, Dr. Patel received Research Merit Awards for cancer research, including ASCO Merit Awards, during his fellowship. Dr. Patel has a special interest in healthcare policy with a focus on racial and ethnic disparities and end-of-life care. An accomplished author, he recently published Between Life and Death, From Despair to Hope, a first-hand chronicle of real patients who have faced the end of life with understanding and acceptance. Dr. Patel is also Associate Editor-in-Chief of Evidence-Based Oncology, a publication of the American Journal of Managed Care, better known as AJMC. Dr. Patel also has extensive experience in revenue cycle management in oncology, including co-founding a large RCM company that has grown from 4 employees to more than 1,000 employees today. He recently started a research enterprise, the Community Clinical Oncology Research Network, to support the recruitment and increased participation of independent oncology practices in cancer clinical research. So with that, welcome, Dr. Patel. That's quite a list of accomplishments there. You're a busy man.
Thank you, Rani. It looks like I'm a jack of all, maybe master of none right now.
Well, I think some people would beg to differ on that. But listen, thank you so much for being on the show today. I am so excited to talk to you and have our listeners have an opportunity to hear from you. Very much, I know there's a lot of people looking forward to your work that you're going to be doing this year with COA as well, and we'll get to that. But I really want to start with just hearing a little bit more about yourself and your practice and your journey into value-based care. So can you give us a little background on that approach that you took and why you decided to leap into kind of this uncharted waters that we're calling value-based care within oncology?
Well, Rani, thank you. First of all, thank you for having me on your show. It gives me pretty good audience for me to share, why we embarked on this journey. But briefly about me, I'm a true nomad of this world, having lived in 3 different countries, 11 different cities. The only thing I can say that my son could never make a permanent friend because I was traveling so much and I was changing so many places. But It also made me a better human being, living in 3 different countries, beginning from India, UK, Scotland, then New York, Philadelphia, and now Charlotte. I realized the diversity that's within all of us and also the spirit of inclusivity. And so when I came and settled down in the Charlotte area, I really started loving this place and then starting our own practice. Just let me show my naivety. When I joined the practice in 2002, I did not know that if a patient had Medicare only, you don't get 100% payment. I had no idea what Medicare is, what Medicaid was. So it was a rude awakening for me. And then within 2 years of starting the practice, I realized that CMS was changing the reimbursement model from the AWP-based drug payment to ASP. And that's the time that came almost like a wake-up call that we had to shift to be more efficient, to be more organized, and to be more structured to ensure that we can continue to serve the patients well. And for those of the listeners who know the South Carolina, it's a tale of two states. One part of the state is almost like a bedroom community for Charlotte. The patients are affluent, the families are well-to-do, they have resources to pay for the care. But the other part where I was practicing, which is in deep rural South Carolina, there were patients who had never crossed Interstate 77, which was just 10 miles from where they used to live. And these were the patients who probably used to live in mobile homes, they were in trailer homes. Some of my patients used to have a big iguana and emu as a pet. So we had a very diverse population of patients we used to serve. And in trying to adjust between the shifting paradigm of fee-for-service schedule and then hearing about, multiple challenges from surrounding large behemoth health systems trying to virtually absorb and take over all the small businesses and then closing down the location that were not profitable and continue with the affluence in the 340B situation, I realized that I had to show that we could convince payer about our survival. We could convince payer about necessity of us being where we were by distinguishing ourselves as somebody who defines the true value-based care. And so I started learning about value-based care, and in the journey from transitioning from the fee-for-service to value-based care, what I realized was that the administrator who was our practice, who ran our practice almost about for 15 years, he had become somewhat reticent and somewhat resistant to any change. So I decided to literally fire him, and I said, I'll take it over. If I could inject poison into my patient's body to get them better, I think I can run the practice better. So that's a transition point when I decided to join the value-based care initiative. And successfully, we shifted our practice from a regular bread and butter practice to NCQA certified patient-centered oncology medical patient specialty practice. So I'll pause here and kind of, share further once you have time to digest this.
Yeah, so that's I actually didn't know that and of you, so that's very interesting for me to hear. And so it sounds like your foray into value-based care was actually very personal. It was fueled by your personal experience. And that's interesting because what typically happens with value-based care is this wake-up call of, we need to actually shift because that's where the market's going, right? But yours seems like a very personal journey into value-based care. So that's very interesting. So tell me about, you mentioned that, it almost seems like that was your first big step was to let go of your practice administrator so you can take over so that the transition would be more centered around value-based care and it could actually happen. So tell me about, I know that your practice has been very successful. You've shared that with me in the past. Can you tell our listeners kind of what is the secret sauce there? How did you make that happen? How did you become so successful in these VBC models that you're participating in?
Thank you, Rani. This is a very interesting question. And then, again, I'm a learner. I'm a lifelong learner. And the day that I say I learn it all, I probably will be somewhere up in heaven or sky. So I'm still learning.
Right. Aren't we all?
We are, exactly. Yeah. So I want to stay a step below perfection. So, when you look into what is the value? And for me, value did not mean the terms of the dollars. When I got our report from CMMI before we started on the oncology care model and other models, what I realized was that at the end of the day, access to care as and when patients need, particularly after hours, was a key to help define true value. So I always think of that 45-year-old single mom who's got three children at home, has a breast cancer, who comes to my clinic for chemotherapy on a Thursday night, maybe about 7 p.m. when she gets a cough, fever. She would end up in going to ER because there's nobody to look after her at the clinic. And when she goes to hospital ER, she'll be waiting in the ER for 12 hours because, by default, ER is always a crowded place where everyone goes for everyone's cough and, sore throat. And then after 12 hours, she'll be hospitalized for mild neutropenia, maybe white count of 3, ANC of 1.5. But she still will be hospitalized because she's a cancer patient. She had a chemotherapy. They'll keep her in the hospital in obstetrics for 2 nights, and they'll send her back on Sunday morning. Yes, story done, successful outcome. No, because that poor girl had to manage 3 kids at home, had to find somebody to pay for them. She had to actually, let go of her 3 days of work. Instead of that, if I could have arranged for her to go to a place, for example, we partnered with a local urgent care, and we gave them access to our EHR, and we gave our cell phone numbers to them afterwards. We said, if you get any of our patients after our midnight, 2 in the morning, just call us on our cell phone. We'll let you know what to do. And so knowing that we spend 50 cents out of a dollar even today on a per beneficiary per month expenses in the oncology space in a hospital bucket, which is the ER visits, hospitalization, observation stay, and rehospitalization, and subsequent cost. If we could touch those expenditures by providing better access and better communication, we could make an impact. So we decided to go for the lowest hanging fruit, which was the access to care as and when we need it. We did a couple of things. One is the open 2 slots every day in a clinic for a walk-in patient. And then we tell our patients who get chemotherapy that if you need to be seen, don't even wait to call. Come to the clinic between 8:30 to 4. We'll get you in. On Saturday, Sunday, our doctors go to clinic for about 2-3 hours in the morning. So if there's an issue that can be tackled then, that could be taken care of. This led to reduction in hospitalization by a factor of about between 25 to 35% given quarter. And that led to significant reduction in total cost of care to the tune that we hit our max savings from the CMMI and we couldn't get any more back. So that was the one secret sauce of success. And the second secret sauce was switching to biosimilars. So, I agree that drugs are expensive. I do call out my industry partners for 2 high-priced drugs. But when the biosimilars were started getting approved, we embarked on that, knowing that we have an FDA-approved alternative for the same indication. Why can't we do that? So that step allowed us to add further 35% savings on a drug budget. So in the 2 pieces, the biosimilars and the expanded access, we were able to succeed in a value-based care. And there was no secret sauce. This was like easily doable, open public information.
Yeah, now that I think that spans across the board, right? We're seeing biosimilars come out not just within oncology, but across therapeutic areas. And I think both of those ingredients in your secret sauce are things that can be taken. Those ideas can be taken and actually applied in other areas. So thank you for sharing that. And that's not an easy. I mean, we talk about it in the last 2 minutes, but it's not an easy thing to implement either. I know there's a lot of things that happen behind the scenes behind those theories, and so to make that successful. So I'm sure it was a ton of work, but obviously the payout is there. I want to just ask you a little bit. I know you've had some really great experiences working with payers, and I know our audience is very curious about the dynamics between the provider and the payer, especially as it comes to alternative payment models and value-based care. So as a provider, so putting your provider hat on, how do you feel the payer world is approaching value-based care in oncology? Are they getting it? Are they doing enough? Are they being more collaborative? Do they need to be more collaborative? What are your thoughts there?
Rani, I've always believed that collaboration, cooperation, and communication are the key to working with the payers. Prior to my taking over the business, I was told that, our biggest commercial payer does not talk to small practices. And that was wrong. What I realized was that proactive approach of talking to payers about what could be done together to improve the quality of care and reduce cost of care can work together. So our biggest commercial payer, which is Blue Cross Blue Shield of South Carolina, which now I have a full disclosure, I'm also a consultant to them and medical director to them, they've been very cooperative. And again, they were actually the first team to direct me to the right direction back in 2012 and 13, when we were almost on the verge of being insolvent because there were some drug companies that had raised the price, and then ASP didn't adjust well, so we were breaking even barely. And that's when actually our commercial Blue Cross recommended that we should look into getting NCQ accreditation. And once we got that, they stood by and they came back with the first pilot. This was more like limited tumor type. It was just an experiment to see if we could work together to define what the value-based care pilot looks like. So participating with the providers and the payers, collaborating with them, help them understand how can we work together where I can bring my perspective of what my patients will benefit from, where I see the group gaps and holes, and where I can proactively intervene to reduce the cost of care. And in a way also impacted because we are a self-insured plan, and for my plan, if I can create a way that we could reduce the total cost of care, my practice will benefit. So providers are open to hear about the pilots and the ideas. The issue with some of my colleagues is that we don't look at the payer as a partner. We look at sometimes them as an adversary. And then give you an example. Recently, one of our peer had decided to take the biosimilars off the formulary. So as we heard about it, we reached out to them, all four presidents, past president, immediate past president, current president, president-elect of the state society, to request the payer to look into what is at stake. Of course, the recommendation came from the PBM, which I call middleman, and the middleman wanted to make more profit on some of the branded drugs for their arrangements with the manufacturers. And then when we did almost like a semi-expose, within 48 hours, they reversed the decision. So I see payer collaboration as a very important part of defining the value and also of bringing the value-based care into the forefront of delivery of healthcare.
It's a great example, actually, of how there's power in a unified voice if the voice is reasonable, right?
Absolutely. Yeah, and then, Rani, our voice was actually focused around patients. So I showed them example that by them shifting over to branded drug, if my patient wanted to have a Neulasta, they may end up in spending about $1,600 more per shot because the AWP of the drug was much higher. And I said, why at the time of COVID-19 you would want to impose additional financial penalty when patients are barely breaking over?
Right. Yeah.
No,
that's a very valid point. So perfect segue into my next question for you. So, obviously you mentioned COVID-19. It's a big area of focus on the long-term implications within oncology. So narrowing that down a little bit, what are your thoughts on the impact of COVID-19 on the future of value-based care models within the oncology area?
COVID-19 actually, the global pandemic makes me lose my sleep, not just because of anxiety about my patients and my employees, but also the delayed screening, the delay in patients' access to care. And between March to June, most of the hospitals where we serve had stopped doing any elective procedures. So what we saw was an onslaught of patients with much more advanced disease. And what I'm seeing post-pandemic is that we'll have a much higher number of patients with advanced disease, which will cost a whole lot more to the system. And combine that with the economic impact on the society as a whole, where we'll have much higher unemployed people, the small business will be barely trying to recover back to normalcy. So what I'm worried about, not current situation, but probably come 2022, where the value-based care model will have defined the benchmark and target price based on 2016, 17, 18 targets. And then when it comes to 2022, the cost, not just for COVID-related complication in the patient, but also the advanced disease will be much higher. So it's going to be all over, and I don't think anyone has a slightest grip or a handle of what's coming our way.
Yeah, it's kind of like that whole unknown, right? And just doing the best you can to prepare for the unknown. Yeah, we'll wait and see. But you make a good point about target price and, the time frame that they use, and is that really going to be the best way to do it given where we're going? So good point there. So just switching gears just a little bit, congratulations on your presidency of COA. That's an amazing accomplishment. And obviously in a year where, we're transitioning administrations and again, we just talked about it, going into unknown waters, if you will. So as president of COA in this very, very formative year coming up, and given the speed at which the oncology space is really evolving, what is your thoughts on the top 3 imperatives that we need to focus on for 2021?
So for 2021, my biggest priority is going to be the healthcare disparities. It's coming to surface more and more, and COVID-19 once again showed us that the patients from the ethnic minority, particularly African American origin and Hispanic origin, are anywhere between 2 to 4 times at the higher risk of getting COVID and also at the higher risk of getting complications from COVID, including hospitalization. Combine that with cancer patients have probably between 2 to 6 times higher risk of getting COVID. So our patients are at 6 to 12 times higher risk of complications from COVID. The second thing is the complete erratic and unstructured distribution of the COVID vaccine, which is another thing that we are worried about most. There's no priority list for the cancer patients who can get COVID, so we are trying to reach out to state health departments as well as health officials to see if we can get into that. And the third thing is, again, about the value-based care, the future of value-based care. We really don't know how long will the extension be granted to the current existing value-based care pilot, and access to care, which is going to be a problem. Large number of uninsured, underinsured patient population with much higher disease, much more advanced disease state. So all of these are actually in our mind to see how can we prepare oncology community as a whole to ensure that the delivery of care is not interrupted.
Right. Okay. Yeah. And I think I read something just the other day around the desire to put these vaccines in the hands of oncology providers, and it makes perfect sense. So for these folks that are so at risk to have access to the vaccines as quickly as possible. So appreciate that initiative. Now, let's talk a little bit about your recent accomplishment. You recently authored and published a book, Between Life and Death, From Despair to Hope. I read it. It is an amazing book, and in fact, my husband had no idea, and we shared a Kindle account, and he picked it up on his Kindle and started reading it. He goes, "What is this? This is so good," and had no idea. And just an amazing story, and I think you just really artfully and tastefully intertwined this very emotional period in both a patient and a caregiver's journey, right, and end of life. And so tell us a little bit more about, the impetus for this book. Why did you decide to write about this subject? How did this come about? And where do you, what's the next chapter? Because I think people would love to see more from you. And is this going to be sort of the kickoff of a series, if you will?
Thank you.
I'm selfishly asking.
I'm glad you liked it, Rani, and I'm glad your husband also liked it. And by the way, the signed copy is on the way for you to keep it as a token of appreciation.
Perfect.
So.
Thank you. I was going to ask you, but I was going to do it off air. So.
No.
I appreciate it.
Yeah.
Thank you.
So having practiced oncology in 3 different continents again and in different health systems, what I realized was that no training ever prepared me to handle death of my patients. And when I would have to speak to patient about, switching the gears to comfort care, you would see reaction, grief, shock, anger, frustration. They feel that I was failing them, all of this multiple reaction. And struggling to kind of, deal with that, I came across a training program at Northwestern called EPAC, Education in Palliative and End-of-Life Care. And I took that training. And then this patient, one of the brightest guy, Harry Falls, I've changed his name. He was a British pilot and he was diagnosed with advanced cancer. And he was very upfront. He said, I come from England. We have a health system that is very well structured. We have a hospice system. So he said, I am not going to take any treatment. No offenses to you, Dr. Patel. But also here you are a very good counselor. He said, two things I need to learn from you. One is what is death? And second is how can I prepare my family for my death? He said, I'm not worried about me dying. I'm worried about how will my wife and my daughter handle my death. And after thinking through this, how can I help him? I told him that, we have this beautiful dome in our clinic. It's an outdoor structure. So that we can sit here every Wednesday afternoon. Wednesday is my half day. I can narrate you some of the stories of my patients. And then, let me know how it helps. Coincidentally, I also told him that I make a home visit. So once I place my patients in the hospice care or comfort care, I do go to their home towards their last days for a complete closure. So I narrated my own experiences of being in the presence of dying patients when they were leaving this world. And he was quite intrigued by that. And he almost came to terms with it. And he said, Doc, I'm ready. But he said, I'm not ready for my wife to witness my death. And it happened that, I went and saw him a night before he passed away. And next day, his wife called me and said, Harry passed away yesterday around 1 in the morning. And I said, what happened? She said, it was strangest thing. I said, what? She said, all of a sudden, my cats jumped out of the bed, and there was one window was open because it was spring morning and early morning. He said they jumped out of the windows, they went out. So me and my daughter ran out of the house. There was nothing. And when we came back, Harry was no more. Mm-hmm. So I felt that, there are some things that we really never realize how even our pets listen to us. In Harry's case, it was a perfect example where their domestic cats enabled Harry to fulfill his desire of living this physical body or mortal remains by himself at his own terms and conditions. And for me, this was, again, another experience that I felt I need to share with the rest of the people. And then during narration of the stories about different patients, I also kind of shared ideas about death and immortality and mortality from different faiths. Again, I'm a lifelong learner, so death is one topic I've learned a lot, beginning from the Egyptian days to modern days, including the World War I and II, including how the funeral homes came into existence. So narrating those stories, I realized that if I create a manual of training for my physician colleagues who are struggling to discuss openly about death and dying to the patients, hopefully this will make a difference in their life.
That's amazing. It is such a topic that we will need to continue to learn about, and every story is different. And I really commend you for taking this on, because as a provider as well, I know that it's a very emotional journey as a provider to guide
Indeed.
someone through this and to experience loss, right? People don't think about it that physicians also experience loss when they lose a patient. And so, really, really wonderful job, Dr. Patel, on this book. I encourage our listeners, if you haven't picked it up, to please do yourself a favor. It's a very easy read. It's engaging, and before you know it, it's done, and kind of leaves you wanting more, which is great. It's a great compliment to the author. So, Dr. Patel, where can folks find your book?
It's on Amazon. It's published by Penguin Random House, which is one of the biggest publishers in the world. Mm-hmm. And it's on Amazon Prime, so you could buy it at one click. It's also on a Kindle as well.
Perfect. Yep. And that's where I got mine. And I can't wait for my signed copy. So thank you for sending that along. Well, listen, I really appreciate you taking the time to talk to us today. I know that we have a lot of folks that value your thoughts and your opinions, and just a real treat to be able to hear from you. Thank you again to our listeners for joining today, and look forward to having you join us for our next episode, Value-Based Care Perspectives. Thank you.
Thank you, Rani. Thanks a lot, and good luck to all of your listeners, and stay safe and healthy.
We hope you enjoyed this episode of the Value-Based Care Perspectives podcast. To learn more about value-based care and healthcare transformation, or if you'd like to be a guest on the show, visit www.vbcperspectives.com.